What is going on, guys? This is Dr. Ryan Gardner with Apothecary Wellness. Today's video, we're talking about some fallacies that exist in healthcare and in health benefits. The first fallacy we're talking about is this concept that providers aren't wrong. The idea that care exists exclusively between provider and patient. And on the other side of the equation, we have this fallacy that exists that things like prior authorizations, which insert themselves in between the care between provider and patient, are guiding providers towards the most cost-effective solution. And this video is not a knock on providers whatsoever. They are the backbone of healthcare, but I will frequently see comments, posts, I'll hear things saying that care really should only exist between provider and patient. And with statements like this, we forget that these physicians and providers are human. Despite their specialty and their expertise, there always is that possibility that they are wrong, or not necessarily that they're wrong, but they are not the most correct. This mindset also doesn't take into consideration the payer, who is the other party involved who reimburses that provider for the care they provide. A thought that came to mind that is kind of like the situation is when we think about a professional athlete. Even then, some of the best athletes amongst professional sports. Think about guys like Aaron Judge. We know this guy is an absolute monster. He's a beast when it comes to hitting home runs. But we saw in the 2024 World Series that the Yankees against the Dodgers, guy kind of went missing. And just because he didn't show up in the World Series, nobody is doubting his ability to swing a bat. But what it came down to is he didn't have his best performance and needed his team to be able to come through and pick up some of that slack. And when we look at the system that we currently have in place for providers, which is predominantly fee-for-service, we're really minimizing what they can do with patients. We're minimizing the amount of time they have with patients to educate them. We're minimizing the amount of time they have to identify and research solutions for individual patients. And we're speaking from a medication perspective. A lot of what they're prescribing is things that they believe can have success for these patients with a more hands-off approach. There's no guarantee they'll see this patient in the upcoming months, and they want to prescribe something that is going to minimize side effects, but still achieves the goals that they're setting for this patient on their next follow-up. So we're really not saying that providers are wrong. What we are saying is that they are often wanting to jump a few steps, make things a little bit easier for themselves and their patients, and that ultimately stems from the system that we have arranged for them. So then we look on the other side at things like prior authorization and step therapy that get involved. It's a way for insurers to get involved with this care. And they act kind of like a system of checks and balances, the way that our US government has. It ensures that the payer or the insurer, whoever it may be, has some kind of say and are represented in between this relationship between patient and provider. Now, in theory, it is a great concept. We are making sure that whatever's being prescribed for this patient is going to benefit them, that the outcomes that this drug achieved in clinical trials that ultimately got it FDA approved will be something that we believe this patient will achieve by being prescribed this medication. But due to some bad actors in the world of healthcare, prior authorizations have unfortunately become a tool that deters or denies care. In fully insured models where insurers are trying to keep as much margin as possible, denying care ultimately means that they're holding on to more money. Even in other models, prior authorizations can divert care to drugs that are going to elicit a higher rebate or a higher GPO fee paid out to PBMs. And even in the most altruistic form, prior authorizations still have the ability to frustrate clinical staff, from providers to their nurses to their medical assistants. It delays care for patients who ultimately may abandon the therapy altogether. And the interesting thing is that prior authorizations are essentially a checklist. You can almost Google any drug's prior authorization criteria list for almost any insurer, and you'll see that it is almost a flow chart where you answer certain questions And if yes for this, do they also have this, this, and that? If no, is it also this situation? And when we look at it, it actually mimics the clinical trials that got this drug FDA approval. It almost mimics the inclusion criteria for the individuals who were enrolled in the study. And there's really nothing wrong with this concept. We do want to make sure that we are going to achieve similar outcomes to those that were found in clinical trials with the patient who is now being prescribed this very same medication. The biggest problem here, though, is that it is a very stagnant barrier. It is very two-dimensional. It is kind of a yes, no, approved, denied kind of thing. It is not actively identifying solutions. So even if this patient does qualify for this medication per the prior authorization criteria, there's nothing saying, hold on, what have we missed? What steps could we have taken otherwise to mitigate the use of this medication? What alternatives exist that we could be using to achieve the same outcome? If the medication gets denied, is there a clinical team reaching out to the provider who originally wrote the prescription to help them identify a way that we are going to get this patient to goal without using that medication? And the answer is no, that doesn't exist. It's simply approved or denied. The checks and balances in healthcare that exist are a good thing. The concept is great. Nobody's perfect. Nobody always does everything correctly. And we've really limited our providers and their ability to develop unique solutions for every patient. Unfortunately, it becomes kind of like a mill, and we end up prescribing some of the same stuff. We can develop prescribing habits that really aren't curated to the individual, and sometimes these prescribing habits can be pretty costly. We also don't have this alignment between provider and the payer. CMS is closer to this with star ratings, but providers really have no accountability for the health plan who is ultimately reimbursing them. On the other end, we have prior authorizations and step therapy in place to make sure that plan members aren't utilizing medications unnecessarily. But prior authorizations aren't doing everything we believe them to be doing. They're not making sure that a medication is the most suitable for a patient. They're not identifying medications that would help that patient reach the highest level of outcomes that we're after. And more importantly, they don't work with providers to identify alternative solutions. Thank you guys for tuning in. Check out our other content here on YouTube and find us on LinkedIn. Take care.